recording. I'm gonna go chatting. Gameplay. Hello? Is there anyone out there? Good afternoon. Welcome again to volume 78 of the CDT Study Club for Russellville Dental Laboratory. Today we will be focusing on the same thing we've been focusing on, which is preparing for the CDT exam, the Certified Dental Technician exam from the National Board of Certification. Before we begin, I need you to know we appreciate that you're here, that you're taking time in your schedule to do these things, and thank you for whatever you contribute, genuinely, because I hope that this is an everlasting project that can be worked on by many people after us, both in our organization and outside our organization. Whatever you can contribute is good. That being said, let's take a quick 5-minute tour to make sure we all know where we are. The goal here is to create a shared study document that lets everybody see exactly what we're working on. We can basically have a master study document for the comprehensive exam for the CDT. Also, if you're just now using Google Slides for the first time, there's a few things you need to know. First of all, if you want to create a slide, you can just hit this plus sign. It's going to create whatever you are here. So for example, let's take this slide. This slide is here's our layout right here. This is a blank slide. So if I hit a plus sign right now, we're going to get another blank slide. So here's another blank slide. If I have a slide and I want a different layout, I can just simply click layout up here and I can select a different type, and that changes my format. So those are things that you need to know. I'm going to go ahead and delete this, and I'll probably do that again. That seemed to work pretty well. I'm going to do that again. Also, this is the list of materials that we'll be using. Almost all of these materials are available here at Russellville Dental Laboratory. There's a couple that we're trying to get our hands on, and there's some on order, specifically ceramics and crown and bridge. Sarah, if you're watching, we're getting these all ordered, all up-to-date versions. The rest of this here is for complete dentures, which is what most of us are doing. You've got the complete denture, a clinical pathway, second edition. And for everybody else, I think Kelly is working on orthodontics. So if anybody else, that's the stuff that you need here. But most of the books we're going to be using, the biggest one we're going to be using is the Dental Laboratory Technology Program from the United States Air Force. This is an open source document, y'all. So just so you know, this is taxpayer paid for, so it's ours. It's free to use as we see fit. I don't know what the attribution stuff is, but certainly using it to make a study guide for itself is fair use. The other things that we have here are all copyrighted materials: Principles of Design and Fabrication, Mosby's Dental Dictionary, or some other dental dictionary, Wheeler's Dental Anatomy, and I don't think this is in print anymore either, so we're substituting in a different one. It's if you Amazon search for dental anatomy, it's going to be the one that pops up. It's really cool, like black and green and yellow cover. And then dental materials and their selection, also out of print, and the complete denture clinical pathway. Dental materials and their selection and Wheeler's Dental Anatomy are both available used online pretty easily, but you have to look for them. And then when you're working on stuff, just try to make a point of like identifying what you're working on. Let's talk real quick about the exam content. We've talked about it before. We've got 31, the biggest portion of it is going to be materials. Then you've got safe working environment that includes stuff like OSHA. Then you've got your anatomy content, then industry guidelines and impressions and models, and then a little bit on theory and articulation. We've broken that out into slides that tell us exactly what we're dealing with. So here we have dental laboratory industry regulations and scope of practice. So these things are specifically there, and I think I'm probably going to try to round this one out here. I think we can probably close this one out tonight. Yeah, that's going to be my plan of attack. And then we've got anatomy. This one is going to be a lot of stuff that you're going to have to study on your own. There's really no way to go about this. Like, you're going to have to, I'm adding stuff in as we go, but you're really just going to be able to have to say, okay, that's the, I don't know, central fossa. That's we're going to put it all in here, but it's really just going to be memorization work is what I'm trying to drive home. Then we've got theory. I'm going to try to do a little bit, if I've got time at the end, I'm going to do a little bit on the theory stuff, but that's define dental terms using appropriate terminology. So how do you define terms using terminology? And identify function and types of dental devices, appliances, prosthesis restorations. That's a really vague statement, but we'll I'm just going to go with it's wanting broad strokes. And then there's some stuff on articulation, and then the big one here is materials, which is identify the types, processes, physical properties, and handling characteristics of gypsum products, waxes, metals and alloys, plastics, resins and composites, separating materials, fluxes and anafluxes, alcohols, acids and neutralizers, wetting agents, wax solvents, abrasives and polishing agencies, laboratory gases, investments, impression materials, ceramics, weights and measures. Then we have working with impressions and models, and then we have safe working practices. Oh yeah, safe working. Okay, so this is, some of this stuff is cross-referenced, but yeah. So then I've just broken it out into the various sections. It is 6:05, so I've spent exactly 5 minutes on this. So then we've got Part A, Dental Laboratory Industry Regulations and Scope of Practice, and we have just begun adding in slides that will help us study for this. If you have previously taken the CDT test or know any portion of what needs to be contributed, please go to that section and add in your thoughts or notes, even if it's just a comment on a slide to help us improve and get better. You cannot do anything wrong participating here. Everything that you do is going to move you a little bit forward, and it's going to help us move a little bit forward. So whatever you do to participate here is much appreciated. All right, so that is it for, let's talk about the CDT exam itself. It is 3 exams in 4 years. If you complete the CDT exam, we will pay for the exam. We will pay for your travel expenses related to going to the practical exam, the hands-on exam. We will pay you $6,000 the first year after you get your CDT, and it sure as hell does not hurt your employment options and your growth options. This is that other dental materials book my lovely assistant Vanna over here just brought me. So this is the one that we've been like alternatively going to. This one's fairly cheap and inexpensive on Amazon. It's done by Elsevier. And does this one have text on? Have you checked this one online? Does this one have like its own thing?
It does, and I would like for you to sign up for those things. And this is courtesy. Kelly is actually the one who found this book. And
Okay.
It's wonderful.
Kelly found this book. It's wonderful, and we're going to sign up tonight as part of this to get this. So we'll see what's involved with going to evolve.elsevier.com. We'll go ahead and get that taken care of. Is that cool? All right. So I'm going to go over here. Whoops. Don't need to show you the code behind. Pay no attention to the man behind the curtain. Evolve.elsevier. Nope. There we go. Evolve.elsevier.com. Boom. Yeah, we'll accept your. I'm a student. Yes, I am. Evolve stay free with textbook purchase, and I'm going to look in my textbook here because there's probably a code or something very obvious.
I didn't see it either.
Okay, so I just have to search for this. So on the back, I'm going to use the ISBN. It is 978-0323-31637-8. Spent a summer in a testing lab. Learn 10 key. It's great. Go. Okay. No, I don't want. No, I want to know resources. Haha, register. Free. No. I bet I do have an Elsevier account. Do I have an Elsevier account? I do. So I want to sign in, and I'll use my. All right, ladies and gentlemen. All right, so we're going to try this again. just going to hit this little button right here. I'm going to do it. Copy. Control V. There we go. Oi. You're killing me, Smalls. Why does it have to be 16 characters? I don't know, because we want to be a jerk about things. We want to control your life. Dental. It's not. I said I was a student. I didn't say. I don't want to tell you about this stuff. Continue. I'm just going to skip it. Basic science. There we go. Year of graduation, 25. Continue. Sweet. Sure, update that. That's great. Now, submit. Get started in my Evolve account. All right, what do we got here? I understand that your grades may not be sent to your course's grade book if you access Elsevier applications and resources through Evolve instead of your school. Oh, yeah. Okay. Don't show me this. I will. We're not going to get in any trouble with the principal. I give you permission. All right. So it doesn't really look like that they actually asked me to do anything. So to prove in any way that I had that book, not that I'm saying that, but I do have that book. It's right here. But it doesn't really look like they asked for any proof of having that book. So again, that was Dental Materials, Foundations and Applications. And that is on Evolve. Whoops. Go down. Evolve.elsevier.com. evolve.elsevier.com. VIER.com. And if you just looked for Dental Materials, Foundations and Applications, when you buy the book, you could just go on that website and quickly sign up for an account, and you could just use those student resources right there. That's very handy. You know, when you buy a copy of the book, right, honey? Mm-hmm. That's right. Let's take a look. Introduction of Restorative Materials, the properties of materials, dental amalgam, cements, impression materials. What do we got here? Instructional videos.
Hello, I'm Dr. Magda El-Diwani, Associate Professor at the University of Texas Dental Branch in Houston.
Okay, so we're going to evaluate.
In this video, you will see how to make accurate diagnostic models from an alginate impression.
That is not from Russellville Dental Lab.
Study models, also called study casts, are a replica of a patient's hard and soft oral tissues. These models are used for diagnosis, treatment planning, or fabrication of home bleaching trays. They are made from dental stone, which is poured into an alginate impression of the patient's mouth. This video will demonstrate the technique of pouring dental stone in an alginate impression and trimming the resulting model. The materials needed are a rubber ball, a spatula, a lab knife, a pre-measured package of dental stone, a water measure, a base former or boxing wax, and a vibrator. Stone should be poured in the impression within 10 to 15 minutes after removing the impression from the patient's mouth. Before beginning, rinse all disinfectant from the impression. Then remove all excess water by shaking the impression.
So there we go. We've got some information there from Elsevier. That was the University of Texas. There's different stuff here. Let's go back and see what else they had. It's not really well organized, that materials there. Oh, you have to go back. So let's see. All right, practice quizzes. Let's see what we got here. Okay, let's see. Blind. Let's see what Lee can do here. Which of the following is a function of an impression material? To record accurately the dimensions of oral tissues and their spatial relationships, to give a positive reproduction of the oral tissues, to obtain a negative reproduction in the form of a model or cast. A negative? All right, so this feels like a trick question. A cast is a positive, and a impression is a negative to obtain a negative reproduction in the form of a model or cast. And that's, see, I think this is wrong. So I'm going to go with, I think these two are backwards. So I'm going to go with here. Trick question. The function of an impression material is to record accurately the dimensions of oral tissues and their spatial relationships. We read that earlier. The impression produces a negative reproduction of the oral tissues. The model or cast is... All right, so I have not watched any further in the video. Let's see if I can pass the next question. An ideal impression material is an alginate. A desirable property of an impression material includes its ability to obtain good dimensional accuracy. So in this situation, it says an ideal impression material is an alginate, and that is too broad of a stroke. So we're going to go with the first statement is false, the second statement is true. Boom. None of the current impression materials completely satisfy the requirements of an ideal impression material. A desirable property of an impression material includes its ability to obtain good dimensional accuracy. Impression materials that are blank when set are used more frequently than blank impression materials. Zinc oxide eugenol impression paste is an example of a blank impression material. So, impression materials that are flexible when set are used more than rigid impression materials. Zinc oxide eugenol, so that would be zinc oxide eugenol impression paste is an example of a flexible impression material. That doesn't, zinc oxide eugenol? What do y'all know about zinc oxide eugenol? Let's find out. It's not cheating if you're not really testing. We'll count this question wrong if you want to. Otherwise, I'm going to take the point for myself. All right, so zinc oxide eugenol. What is a more common name? This looks like Dentsply. Yeah, Dentsply Sirona. What is this? This is Zoe, B&T? Okay. No, I don't know what zinc is. What is... ZOE is... a cement base of ZOE or glass ionomer cement is placed gently over the MTA and allowed to set. So it sounds like this is rigid. The reaction is catalyzed by water and is accelerated by the presence of metal salts. So you've got a powder that you mix up, just like alginate. ZOE can be used as a dental... Whoa, did that pop something new up for me? Or did it just... No, that's weird. ZOE can be used... Okay. Yeah, so this says it's not usually used if the patient has large undercuts or tuberosity, so down in here, because it would capture the undercut, which means it's a rigid material. So we're going to go with flexible, rigid, rigid. Boom. Impression materials that are flexible when set are more used more than rigid materials. A rigid impression material. Boom. We're 3 for 3. Which of the following is a disadvantage of an alginate hydrocolloid impression material? It definitely has low tear strength. So alginate or hydrocolloid, the blue stuff. But alginate hydrocolloid would be that flexible material. That's the stuff that we've got to pour up pretty quick. I don't know what 100 hour is. Let's see what 100 hour alginate is. Maybe that has a specific designation. So, all right. So, any who's this? Midwest Dental, first alginate, chromatic phase indicator, AIDS preparation. Oh, I mean, chromatic phase indicator. That is a really fancy way of saying that it changes colors when it's getting, when it's forming up. Chromatic shade indicator. I got to remember that. That is some quality marketing shit. AIDS preparation, variation, setting time, and mouth and mouth. Okay, but it doesn't say what it is. There, maybe this will tell us. This looks like something that would have a good picture. High elastic, improved tear resistant alginate impression material. So, all right. So I'm off the races there. All right. Which of the following is a disadvantage of alginate hydrochloride? It has low tear strength, transfers surface detail to gypsum does better than elastomeric. Minimum equipment necessary for use. All of the above. No. So the disadvantages has low tear strength. Boom. The principal disadvantage of alginate hydrocolloided impression material is that it has low tear strength. It is a disadvantage that alginate materials do not transfer as much surface detail to gypsum dyes as elastomeric impressions. It is an advantage, not a disadvantage, that alginate material uses minimum equipment. This water that I just drank is definitely old. All right. Question number 5. The purpose served by sodium phosphate in the alginate powder is which of the following? So sodium phosphate. All right. To act as a retarder, which would be to slow it down. To control the time of setting, which is the same thing. Well, I mean, basically. To react preferentially with the soluble calcium ions. So we know sodium, calcium would be, I mean, just off the top of your head, you know these things, right? So we're going to go with all of the above. Boom. The manufacturer controls the time of setting by the amount of sodium phosphate present in the alginate powder, and it puts it in soluble calcium ions, probably in the form of, what is table salt?
NaCl.
Which is nitrogen, no, it's
sodium chloride.
Sodium chloride, soluble calcium. Nope, I'm off balance. It's not salt. Anyway, we got it right. Which of the following can contribute to increased permanent deformation of an alginate impression? Well, permanent deformation of an alginate impression occurs when there's basically any pressure on that alginate material after it's been removed from the oral cavity. So you'll see most often we see alginate materials delivered to us with like a wet paper towel wrapped around them and a little in the plastic baggie and whatnot. So we don't want any pressure on them. So which of the following can contribute to increased permanent deformation of an alginate impression? So it says thicker mixes. I don't know. We're supposed to use the manufacturer's recommendation there. So decreased time held under compression. Decreased time held under compression. Increased deformation during removal. Which of the following can contribute to increased permanent deformation of an alginate impression? I'm going to go with all of the above again because I'm going to presume that decreased time held under compression. So this is taking it out of the mouth too early, and this is torquing it when you're taking it out. And so I'm going to assume this is correct. So we're going to go with all the above. Ooh, he gets one wrong. Casey is no longer at bat. Casey has struck out.
No, not after one.
Yeah.
No, that's just one.
1 out of 20, I failed.
Oh,
All right, so permanent, so we got this wrong. We got this wrong. That's the collective we, right, honey? I'm getting flipped off. You can't see it off screen, but it really is happening. Which of the following can contribute to increased permanent deformation of an alginate impression? Increased deformation during removal. So don't torque it when you're twisting it out of the patient's mouth. Question number 7. Which of the following would you expect to occur with a thicker mix of alginate impression? I would assume it would make it stronger, which would make it less flexible, which would make it set time faster because there's less water to powder ratio. So we're going to go with all of the above. The strength of alginate impression materials is increased if thick rather than thin mixes are used. Thicker mixes result in decreased flexibility. Thicker mixes shorten the time required for materials set. Yeah. So you can, roll your own speed there on alginate apparently. Question number 8. Which of the following are important considerations in the storage of alginate impressions? Hydrocolloid gel contains water, so it will not absorb additional water while soaking. Impressions should be stored under conditions of 100% relative humidity, so that's basically what we do. Alginate impressions will shrink if not stored in water. No, that's not. Impressions should be stored in air to prevent water absorption and expansion. So alginate impressions will shrink if not stored in water. Yes, that is true, but which of the important considerations in the storage? This is it. Impressions should be stored under conditions of 100%. Yeah. Boom. Alginate impressions can be stored under conditions of 100% relative humidity for up to 5 days without serious dimensional changes. Cool. Which of the following are considered a best practice when dispensing the alginate impression material? Dispensing the alginate impression material. So this should be the powder into, you've got your little mixing bowl, and you're doing like for us it would be a duplicate denture, but or the old school duplicate denture. But if you're assisting, so you've got your bowl, you've got your spatula, you've got your powder, you scooped it up. All right, so dip the powder scoop lightly into the powder and tap the scoop to ensure a full measure. Aerate the alginate powder is the same thing as sift the powder into the water, because I mean both of them are just putting extra stuff in. I don't know about that, but dip the powder scoop lightly into the powder and tap the scoop to ensure a full measure. I'm sensing a theme here. Are we gambling? I'm gambling again. All right, all of the above. So sift the powder into the water. Those of you who are watching out there who may have had previous assisting experience, did you have like a flour sifter that you used to get alginate into the bowl? I don't think so. All right, we'll go on. Question number 10. Of the following, which factor would cause the alginate to set before a satisfactory impression is obtained? Unusually high room temperature would decrease the relative humidity. Use of cold water. Aerating the powder before dispensing. Incorrect seating of impression in client's mouth. Of the following, which would set before a satisfactory? So it's either a high room temperature or use of cold water. And I'm going to go with high room temperature. Boom. Yeah, so when it's hot, and that's one of the great things about our new facilities, we got more humidity control than we had before. So, all right. And if anybody's watching and you're actually working on the slideshow right now, that's great. This also, going through this stuff and talking through this stuff is a form of study too, I think. Is that correct, Amanda? All right. Question number 11. Which of the following suggestions will help to minimize the incorporation of voids into the alginate mix? Not talking about alginate impressions anymore would help. Squeeze the alginate. Yeah, so this is going to be it. Fill the tray from the metal spatula with the metal spatula by approaching it from several directions. So when you're filling your tray and you've got your spatula, so my nail file is going to be my spatula. What you do, you'll notice that if you've ever seen an assistant do this, they've got their alginate material on there and they scoop it into the tray and they get more and they scoop it and they're turning the tray the whole time that they're doing stuff. And that is to make sure that they're in that flick of the wrist there, that's to push that material down into the corner so that you don't get air bubbles that pop up and that come out and in the form of voids, right? Especially like the cusps and things like that. That's where those voids come from. It's not that they mixed it poorly, it's that they didn't get it, like they left an air bubble underneath that impression. Frequently it'll pop right back up. You bite in, that's where the air finds a little trap to come up and you get this little crease. So we're going to say fill the tray with the metal spatula by approaching it from several directions. Squeeze the alginate between the blade of the spatula and the side of the rubber mixing bowl. Did you like that noise, by the way? I'm sorry, I forgot there was a microphone like right here. Squeeze the alginate between the blade of the spatula and the side of the rubber mixing bowl. It wasn't cheating, Cody. It wasn't cheating to... All right, I took the L. All right, it doesn't count. So my score is now, it says 11 of 20, but it's actually 10 of 20 according to new rules. So I'm 50-50, no, I'm on question 10 of 20, and I've gotten some amount right. We'll see. The method used to ensure that the vestibule is recorded in the alginate impression is which of the following? Let's do some fun stuff here, because I actually pulled this up earlier. And I'm going to pull this over to the screen here. So let's talk about impression. So this is going back to the Air Force manual. They're doing alginate there. That's the technique I was talking about. But that's pouring stone into. Where did that go? There's a really good graphic right up here. Here we go. This is really cool. I like this quite a bit. So I'm blocking things. Can I unblock that? I need to make myself smaller. I know the audience is going to hate this, but I'm actually going to reduce my imprint on the world. Y'all bear with me. Thanks. All right. Save. All right. So this, why does the chat stay on forever? Animate from left, auto remove messages, remove after 30 seconds. There we go. And save. Boom. All right. So this is our impression. So this has got it labeled. So we were looking at, it was saying the method used to ensure that the vestibule is recorded in the alginate impression is which of the following. So let's make sure we're all talking the same terminology. Vestibule, vestibular ridge, mandibular arch impressions. Is there a maxillary arch impression? Here we go. Vestibular ridge. I'm not seeing it. I know it's there. I'm missing it. I'm tired. Jeez, oh Pete. Okay, so I'm going to pull out of this because I'm not seeing what I expected to see. I thought since we were talking about impressions that we would be able to come over here and look at this, but this is a really good graphic in the Air Force manual. If you pull it up, if you're using your PDF reader, it's 204 and 205. It is identification of maxillary and mandibular arch impressions, casts, and dentures. So it shows you comparison of some of the terminology that we use. For example, number one over here is the vibrating line. So you can see the vibrating line in your impressions usually as like a transition area where it goes from being the hard palate surface into the soft palate. And you kind of see it almost like a floppy section at the back of the impression, because that's really how the soft tissue deforms when the pressure of the impression material gets up there. Then that's your vibrating line, that portion where the soft tissue and the hard tissue meet. So if you run your tongue back in your mouth all the way to the back of your mouth, you'll feel this area where it transitions from hard palate to soft palate. That's your vibrating line. Just in front of that is your fovea palatine, which is marked here as number 5. So palatine fovea area. And you can see that in your impressions. Usually it's just two small little nothing. Like if they're hard to spot. But you can see how now, if you look at this from the impression, we take from the area of the vibrating line forward to make our butterflies in our dentures. And that's where your post-palatal seal is. Something that, by the way, in digital dentures seems to be essentially nil. The reason for this is we don't need any sort of post-palatal seal in digital dentures, or at most we need just like a simple 1 millimeter bead. And that's because digital dentures are designed so intimately, either with the tissue scans or with the hard tissue, like the hard model, that there's less distance because there's no dough packing, there's no pressing the material onto the model. It is just designed free of the model. So the fit is so intimate that as long as you don't have extreme undercuts and you have to block out those undercuts, you can basically just slide those digital dentures in and they're going to stay because the fit is really tight and there's just the moisture in your mouth is going to hold them in place. That's been our experience thus far. But on traditional dentures, we had a post-palatal seal that you most commonly seen being scraped into. Trevor is working on those models when he's investing, and he'll come into the back of the model and scrape through it. Sometimes you'll see him bringing one it's ready to be processed. He's bringing it to have it inspected. It's because it's hard to see exactly where the vibrating line is. It wasn't clearly marked, and that's what we're doing there. And then going all the way over then to the denture, you can actually see what's labeled for, you've got your posterior post-palatal seal area. So in the middle it's D, so that's what's implied. And then you've got that, where that seal is basically just, it's just two little thumbprints right up there in the back of your mouth where the soft tissue meets the hard tissue to hold that denture in place. It's kind of like a little suction cup on the back there. Really good graphics. You should take a look at them in the Air Force Manual. Again, Air Force Manual Volume 1 in your CDT manual. Oh, by the way, since I've got it up right here, I just want to say, if y'all, go to log into your Google Drive, and you should see RDL Employee Experience here, and inside that folder you may not see all of this stuff, but you will see NADL CDT Library, and in here you've got all of the stuff that we've been working on, plus the CDT Study Club Comprehensive Exam Study Guide. This is the thing that we are actively working on right now, and I've got this open in this other window. So moving back then to what we're working on. Ooh. I'm going to go after that one section now. I'm going to see what I can figure out. So, dental laboratory industry regulations and scope of practice. All right, let's get into this. Dental laboratory industry regulations, scope of practice. Understanding good manufacturing processes. So we've got, so let's see. Let's see what we can pull up on our document here. I'm going to take this to here because it's easier to see. I'm going to take it to good manufacturing processes. So I saw this flasking compression molded denture bases. So there's microwavable compression flasks. And then I was looking for, no, it would have been up in model preparation. I was looking for that Phobia Palatine where they did that, but that's usually in model prep. Not everybody does it like we do. Just so you know, the reason that we do it this way, and purists would argue with it, but since we use a light cure base plate for most of our stuff on the maxilla, it's not as intimately fitting as what the processed denture base is going to be at all. So there's no reason to go ahead and put that post-palatal seal in and modify the master cast until we know the clinician is ready to go to final on that case. Since we're not going to get that super like micron level intimate fit with our light cure bases, we don't use that. We don't spend the time to go ahead and put in that post-palatal seal pre-processing. We wait until processing. That way it's fresh and exactly the way we want it. It doesn't get damaged during process or during the try-in process or anything like that. I thought there was a section in here. There was a considerations. There's a consideration section in here somewhere that I saw earlier today. Cusp. Where did you see where there was cusp in form of in cusp position and manner? Cusp position maximum. Looky here. Occlusal patterns associated with basic mandibular Occlusal patterns. That's the problem we had last week, isn't it? Chapter 5. So last week I was stuck on what the hell does this mean, because I did all that stuff on the denture. I had some new slides. And by the way, you can add in animated GIFs into your Google Slides. So if you find any cool ones like that, you can do so. This is some study slides I created late last week. Last week I was working on something, and I got into occlusion. Types of canine guidance, group function, malocclusion. It does not say etc. But this is where I got sideways last week. So I'm going to go ahead and pull this up. I'm going to say mandibular movements, cusp position. Man, I need some chapstick. Darling, love of my life. Have you stolen all of my chapstick?
I mean, it's possible.
Would you mind to would you be willing to share with me? I appreciate that. All right. Cusp to occlusal embrasure patterns, cusp. So it literally says centric occlusion, centric relation, don't use chapstick, drink water. I am absolutely parched. Like, seriously, I haven't drank anywhere near enough water in the last 8 days. But my lips are sticking together while I'm talking. I will use it. It's good stuff. It's not good. It's EOS. It's not perfect, but I'm just going to get me enough to get me through, man. I swear it's my last time. Cody Peevler says it's chapstick. It's bad. I need to drink water. And he's right. But my lips are minty fresh now. I'm sorry. He's a professional. You are an oral professional. Let's see here. Cusp positions and maximum intercuspation. So that's centric occlusion. This is centric relation. All right, so what did the thing say? It said canine guidance, group function, malocclusion. Group function and malocclusion. A little bit while I rub my beard in concentration. It's probably annoying to those listening at home. So there was a section up here that had really good visuals on the jaw relationships, and you got into class 1, class 2. We copied some of this stuff out, right? So you would think that this same information would be right around where the class jaw relationship, all right, I apologize. This is how my brain works, so we're going to try this. Ooh. Nice graphic. All right, I'm gonna find that graphic real quick. So this is flasking. So this would be after the. So I need to go back up. Yeah. Where are we? So we're something in here. Edentulous resorption patterns. That's cool. I actually didn't know that was a thing that you could track it that easily. Protrusive. All right. So we're getting close. Don't tell me it was like right here by where I was previously. Of course it is, because that's what would be funny on camera. Oh, it's a little chart. You can name your own things. No, it's not. It was actually showing you movements. I'm a moron. Here we go. Welcome. So it was right there where I was looking. It was just... Okay, so where is malocclusion? Maximum intercuspation. Maximum intercuspation is the complete intercuspation of the opposing teeth independent of condylar position. In other words, where you bite together, not where your condyles actually are. Sorry for banging into this. Oh, you can't hear on that. Awesome. I'm using that microphone, so I can just stick this backwards and it'll look super cool, because everybody looks cool with a thing sticking out of their head. So when there's a difference between centric relation and maximum intercuspation. If I say bite together, that's maximum intercuspation. But if I want centric relation, I actually take your jaw and I'm going to seat the condyles. Okay, we want the condyles to fall right into their little sockets. So that's the difference. Sometimes patients have wear and things that they have developed over time that compensate, and so maximum intercuspation and centric relationship are not the same thing. Centric occlusion, you can see it should be something like it should be, yeah, just where it's set, the condyles are set. And then this is not a malocclusion. Malocclusion is broader in scope than just the class of occlusion. So malocclusion. Yeah, it was this all along. Congratulations, ladies and gentlemen. You played yourself. I mean, I guess you technically didn't. I did. It was just class 1. So. Yeah, so we're going to bring in this stuff here. So, boop. Just going to paste that little graphic in. It's advanced stuff, kids. Don't try this at home. None of this is how you spell any of that. No. I don't care what you say. None of that's how that's spelled. Centered. Alright, occlusion and malocclusion. I'm going to make another one. I'm actually going to just move this up because originally it said canine guidance. So we're going to go right back to this. Okay, so canine guidance is when you move your jaw from side to side, those are your protrusive movements, which is, hey, Amanda.
Yes.
There's this figure that only exists in dentistry about jaw motion. Yeah. And about the extensive jaw motion, and this image right here is a good example of it. But it's this shape right here, this kind of tooth shape right here, it mimics what the jaw can do. It's like the back and the forward and the whatever of the jaw. It's pretty universal in shape. That would make a really cool art piece. Just that shape, like a big canvas or something like that with just that shape on it, would make a really cool art piece, because it's something like only if you study the way jaws move can you possibly, would you have any reason to know what that shape is? And we can put the little letters on it and stuff like that. That's cool. All right, right and left lateral movements. So there's your right and left lateral movements. The side to which the mandible moves is called the working side. So if I'm distending that way, that's the new working side. And this is the non-working or balancing side. So that would go, you'd have most of your force going to the back or on the back of the molars, whereas on this side you'd be biting, like cross-siding up here. So the non-working, there is a total shift or mandibular translation or side shift of the mandible and its condyles towards total working side. Total shift. Progressive MT or mandibular translation is characterized as the working condyle rotating and moving laterally while the balancing condyle moves forward. So that just means torquing, basically. So the working is characterized as the progressive MT is characterized as the working condyle rotating and moving laterally. Working condyle, while I'm doing this. Working condyle is here. This is the working side, non-working side. The working condyle rotating and moving laterally into this full position. This torques forward and this kind of torques back. Immediate MT takes place prior to the working condyle's rotation or the balancing condyle. So from everything from the moment of center to that movement all the way to the left, that's immediate MT, and progressive MT is when you're all the way there. So this is your movement. So this would be the working condyle. That's the same thing they're doing here, looking top down. Here's your working side. This is your non-working side, and there's your shift. So when test lateral movements are made with the cast of a patient's mouth mounted in an articulator, the maxillary and mandibular stamp cusps move out of MI and follow predictable routes across opposing chewing surfaces. Oh my gosh, why do they have to say everything so complicated? Like I'm verbose. I use a lot of words. I get picked on for the words that I use. Picked on. Oh, woe is me. I get the words that I choose to use are acknowledged on occasion because of their complexity. I'm a pompous asshole. Anyway, but that is ridiculous. The maxillary and mandibular stamp cusps move out of MI and follow predictable routes across opposing chewing surfaces. It's basic. I mean, it's bone, but it's pretty rigid. So yeah, if you move it, everything's going to move. If you move your condyle, also this part of your mouth will move. Got it, boss. The incisal edges of lower anterior teeth. All right, so now the cool part about this, so it gets into Gothic arch tracing. So you can actually translate this movement. This is cool. So for those of you who have not gotten to use a whole lot of the semi-adjustable articulators, you can actually trace this movement. There's a mechanism that you can use with a face bow that allows you to trace this whole movement in 3 dimensions. So we saw it, for example, we saw it here. I was talking about this image. This is only 2 dimensions. So you're seeing what the jaw can do in these 2 dimensions on this image, but the jaw is also moving this way. It's 3-dimensional. So the total movement there is kind of like a shield shape. It's like this. Sorry, this is what everybody comes to Twitch for, is the professional dental imagery, right? So it's like a shield shape. So that image, and it curves under the body, right? I was going somewhere with this. that shield shape, can be captured in a Gothic tracing. So you use a face bow to capture the movements, and you put some material up here, and you say close together, and when you do, that material moves out of the way. You put a little nub on it, and you say move your jaw all around. While they're doing that, there is a thing connected to their jaw. So as they're moving it around, it's capturing all the movements. You can take that and move it onto the bottom of a semi-adjustable articulator. All right, so this is all related, I swear to God. We're all learning this together. It's not everything is about getting it on slides. So you've got your semi-adjustable articulator. All right? These things up here are supposed to be your condyles. So they've got movement to them. You can see these have rubber bands on it to help you move. But if I take this and flex this a little bit, you can see the pin moves. So the top of this pin is a nub. The bottom of this pin is a little scraper. It's like a wedge, it's like a flathead screwdriver, and now it is stuck somehow. All right, so let's try this again. If I turn this flat side, instead of turning this flat side where it's landing down like a screwdriver coming down, but I put it like an edge, like it's supposed to be, and I zero this articulator out. I'm zeroing it out with the top of that thing. Come on. There you, yeah, sure. Run right there. That's cool. See if I care. All right, so we're zeroing that out. Now, if we look at our articulator, we've got a point coming down here, okay? If I take that reverse thing that was attached to my jaw and it's got that little material, I take it out of the thing and I flip that over and I put that right here. Now, the extent to which, I'll pull this off. The extent to which this moves, when it's moving around, is the same to which the extent that your mouth moves, okay? And that is how we accurately record, along with the face bow, the jaw relationship, or in other words, the specific relationship between the condyles and the intercuspation of teeth here. That's really what our bite is. So we basically get a measurement between the condyles and the actual model, and we can accurately transfer. This is not just a fancy articulator. It is the bare minimum required in order to be able to get an accurate translation of the patient's actual anatomical movements to use in the dental lab, basically. So that's how we get all of these three-dimensional movements, and this is why we have our own vocabulary, is because we had to create an entire way of communicating about, no, when the jaw goes that way and down, or we had to have a way of saying, you know, when the teeth touch, no, when they really touch. So maximum intercuspation is like, no, they really touch, right? Centric relationship is different. It's where the condyles are seated, and I might, at one point in my life, I only had like contact on one molar in centric. So you could pop me into centric, and it would just, like, I would have this one little point of contact back here, and everything else would just be an open bite. Now you could probably, you could just pass paper in there, but it's enough, we know that there's enough tension between your teeth that you know that you can feel that there's no contact, right? Just like you can feel a grain of sand between your teeth, you can feel when there's no touching whatsoever. So that's what an open bite is for us, and that's why sometimes it's really hard for us to see the doctor sent something, but the bite registration material has no see-through on it. Like, there's no window showing that there was compression on any of the teeth. And when we take the models and we set them together, you've seen your manager do this probably, they'll set them together and they go, man, these teeth should be touching. And then they put the bite in there and they go, these teeth are not touching, because they can see in maximum intercuspation they should be together, and we know that's where the bite was taken, right? So that means that the bite was not fully seated. The condyles, or the jaws, the maxilla and the mandible did not accurately go together in that capture of the bite. So you'll see your manager take the bite out and just stick them together and go, this is going to be more accurate, because it's better to do that. In many cases, our clinicians would prefer us to do hand articulation than they would us to produce something that we know is open unintentionally 1 to 3 millimeters and is going to cause the problems. It is 7 p.m. Thank you, Cody. That is all for tonight. That is your miniature lesson for articulation for tonight. This has been a lot more fun. I hope this one actually does make it up online and would be useful, and we'll continue adding stuff to our presentation. So I didn't really get through that whole thing, but next week on CDT Study Club at Russellville Dental Laboratory. Thank you for joining us.